This week on the BackTable podcast.
So we've approved a patient, and what happens after that? Are they going to get their liver the next day? Or what happens?
We keep trying Amazon and they're all out of livers. It's not working. I even got Prime. That becomes complicated. So once they're on the list, then it sort of depends on how sick they are, is one answer to that. Patients who come in with really decompensated liver disease and a very high MELD score can get transplanted the day after they get listed. It's not never happened, but they can usually get transplanted pretty quickly. The trick is that we have a system that prioritizes the MELD score for highest MELD score, right? So if you have a high MELD score, then you can get transplanted pretty quickly. But even if it's the mean for that area or below, then the waiting time is highly variable and often quite long. So the reality for the patient is they just got approved, they know they need this therapy, and there's extraordinary anxiety because we can't just tell them when that's going to happen.
Welcome to BackTable Tumor Board, your source for the latest on multidisciplinary cancer care.
All right, well, welcome, guys. We're going to be talking about the transplant approach from both surgical and medical perspectives. I'm Zach Berman. I'm an interventional radiologist at UC San Diego, and I'm joined today by...
John Seal. I'm a transplant and hepatobiliary surgeon. I practice out in New Orleans at the Ochsner Clinic.
I'm Heather Patton. I'm a transplant hepatologist and a practice right here in San Diego at the VA healthcare system.
And I'm Stephen Young. I'm also a transplant hepatologist. I practice with John at Ochsner in New Orleans.
Great. So could you tell us a little bit about what your practice pattern is like? How many transplants are we doing here? How many patients are we seeing?
Yeah, so at Ochsner, we do about 150, 160 transplants a year. About 10% of that is living donor transplants. The rest are deceased donor transplants. That volume's been relatively stable for about the last 10 years or so.
Yeah, so my practice is about 50% general hepatology, so anything from elevated liver tests, fatty liver, to decompensated cirrhosis. And then the other 50% or so is transplant, both pre- and post-transplant care.
So my practice is primarily general hepatology, but we do take care of pre- and post-transplant patients when they've returned from the transplant center.
Perfect. I think a good place to start is what's just the general data on transplantation? How is success measured? Is it 1 year survival, 2 year survival, 5 year survival? What sort of benchmarks are we looking at trying to hit?
Yeah, I think the big ones we look at are 1 year and 3 year survival. I think that's what UNOS measures. We have to report, other things that we look at are graft survival, in addition to patient survival. If they develop recurrent HCC, if they're transplanted for HCC, some of the big metrics we look at.
Yeah, I think it brings up a good point because this sort of frames the whole therapy of transplant, because with a lot of cancer therapies, if we get a 5% survival, we're like, oh, we made some ground, right? But when you're talking about transplant, you have a scarce resource that's shared. And so the benchmark is for 1 year survival, it's around 95%, 90 to 95%. And your 5 year survival should still be around 80%. So when we start this conversation about doing transplants for cancer, we really have to have a combination of therapies that will allow us to get the same type of survival that we get with transplant for other reasons. So I think that kind of is in the background when we talk about transplant for HCC in particular.
I think it also helps to set a benchmark for as cancer therapies evolve, assuming that the liver function is adequate, can we reach those same benchmarks without transplantation?
Perfect. And since you brought up our first acronym, I'm sure of many acronyms we're going to talk today, what is UNOS?
Yeah, so UNOS, United Network for Organ Sharing, they sort of regulate transplants in the United States, not only liver, but other organs.
Okay. And so every single center reports the same place, or is there regions for UNOS, or?
Yeah, there are regions, but there are certain criteria that we have to report to UNOS both before and after transplant that are sort of standardized for each center throughout the country.
Okay. And so whenever you get we're the best center for this size, it's coming from them? All right, perfect. So I think that's going to set us a good backdrop of what we're expecting for the rest of this conversation. So I wanted to start off with the pre-transplant process, right? So someone comes in, let's just assume for right now they don't have cancer, right? They have chronic liver disease. and for whatever reason we think they need a transplant for the chronic liver disease. What's the workup like for that, both from a surgical perspective and a medical perspective?
Well, I'll say for the medical perspective, I mean, first and foremost, the first thing we have to answer is, do they really need a transplant? Because it's a scarce resource, and if the cirrhosis is sort of early enough, they may have superior survival without undergoing transplant. But then after that, what I like to explain to patients about the evaluation is that we want to make sure that they don't have any other health problems that would make the surgery itself too high risk or that would compromise their survival after transplant. And using examples like if, you survive the transplant surgery and then a year later, die from cardiovascular disease or, metastatic lung cancer or something of that nature. So, and then the last bit beyond the medical evaluation is the psychosocial part. Do you have all of the resources that are needed to take care of a transplanted organ? The surgery is the first part. I won't say it's not the most important part to our surgeon, but, for that graft to work well over the long run requires, people taking, often a number of medications, being adherent to lab monitoring and clinic visits and that type of thing. The other thing that is, pertinent in this patient population often is alcohol and other substance use, and making sure that those disorders have been adequately treated with a plan for long-term sobriety maintenance.
Awesome. I guess taking that in pieces, what exactly sort of support network do you need to have? They always talk about, at least at my tumor board, this person doesn't have a caregiver. What goes into that?
Obviously the medical evaluation is really important, surgical evaluation is important, but equally important is the psychosocial evaluation. So we have dedicated transplant social workers who meet with their patients, meet with their caregivers. And so typically we're required somebody to have a primary caregiver is our terminology, so somebody that can stay with them in the peri-transplant period. In reality, it's difficult for one person to take care of another person 24/7 after transplant. They have lives too, they have families, they have life going on. And so we typically require them to have a secondary caregiver, so somebody that can fill in. And certainly people may have more than two people that can take care of them. But, at least once they're discharged from the hospital, especially early after transplant, either, friends or family members that are able to care for them after transplant.
Perfect. How about from a surgical perspective? What's part of the workup for that?
Yeah, we all work pretty closely together. From a surgery standpoint, we routinely get imaging. Most of the time they've had some degree of imaging going into it. That can be a little tricky sometimes because of renal function. I know you all deal with that all the time too. But that's an important part, is just to get an idea of the lay of the land. And really, one of the important things, or probably the most important thing, is to stratify how complex that operation is going to be. So at our center, we use a ABC classification system that helps us kind of quickly understand when we're reviewing the list of the patients, kind of how hard this transplant is going to be. So for an A-class patient, it means no prior upper abdominal surgery. It means all the vasculature is patent, that their BMI is in a reasonable range, and we can probably do the transplant in a couple hours, right? Goes pretty quickly and pretty good recovery. On the other end of the spectrum is, BMI over 50 or extensive prior upper abdominal surgery. And then, of course, portal vein thrombosis makes hooking everything up a lot more complicated. And ultimately, that kind of dictates the type of grafts that we can use down the road, which ultimately dictates how long they're going to have to wait for a liver. So that's what we try to capture in the eval process.
Okay, so they do their entire evaluation, and at least at my center, they have something called a selection meeting, where they either choose to approve or not approve somebody. Could you guys take me behind the scenes and maybe tell me what the discussion is, whether, you make the final approval or not to list the patient?
Yeah, so as at least our selection committee, it's typically the hepatologist who presents the patient. So we'll go through, the etiology of their liver disease, the indications for liver transplantation, what complications they're having. We'll talk about their medical history, their surgical history, and then we'll run down all of the testing that was done for part of their transplant evaluation. So cardiovascular testing, routine cancer screening, things like that. And then at that point, we turn it over to the rest of our committee. So we have social work weigh in, we ask our surgeons to weigh in. We have a financial coordinator as well, making sure that finances are in place, that people have appropriate insurance coverage for transplant. And then we also have transplant anesthesia that weighs in, so talking about the anesthesia risk associated with transplant. And then as a committee, we determine whether or not each patient is acceptable to be approved for transplant.
Perfect. And so does it have to be a unanimous decision? Everyone has to be on board, or?
No. I mean, there are lots of discussions. I mean, there are lots of things that can come up. Psychosocial issues, alcohol is always a big one that comes up. It doesn't have to be unanimous, but...
I mean, to be fair, we don't really vote. I don't know if this is how it goes with y'all, but it just kind of migrates into a consensus. And occasionally we have a split perspective on the patient's candidacy, and that will sometimes play out with more specific taking.
Yeah, and it's not always a yes or no. Sometimes we defer patients, so they're either approved, declined, or deferred. And we can defer them for several reasons. We can think they have, increased cardiovascular risk, and they may need, maybe they had a stress test and we think they need a left heart cath after discussing them. There may be psychosocial issues, alcohol, and we want them to do, more rehab, maybe a formal rehab program for alcohol. So there are lots of, other issues that can come up that we can defer patients, either do more testing, let the patient do more, rehab or a longer period of sobriety, and then bring them back up to a later selection committee.
Perfect. So we've approved a patient, and what happens after that? Are they going to get their liver the next day? Or what happens?
We keep trying Amazon and they're all out of livers. It's not working. I even got Prime. That becomes complicated. So once they're on the list, then it sort of depends on how sick they are, is one answer to that. Patients who come in with really decompensated liver disease and a very high MELD score can get transplanted the day after they get listed. It's not never happened, but they can usually get transplanted pretty quickly. The trick is that we have a system that prioritizes the MELD score for highest MELD score, right? So if you have a high MELD score, then you can get transplanted pretty quickly. But even if it's the mean for that area or below, then the waiting time is highly variable and often quite long. So the reality for the patient is they just got approved, they know they need this therapy, and there's extraordinary anxiety because we can't just tell them when that's going to happen. So the waiting time can vary quite a lot. I think if we think about this in terms of transplant for cancer, then there's a system by which even patients with low MELD scores will get more. We may tackle that in a little more detail.
Second, yeah.
And that's going to dictate also when they get transplanted.
So it's based on MELD score.
MELD score, go home, pack a bag. We'll call you when we got one.
Yeah. Okay, great. So kind of building upon that, most of our patients are going to get transplanted immediately, and they might have a bunch of other issues going on medically that might need to be addressed. So I think the first one I want to tackle is portal vein thrombus, and we're still not in the cancer space. We'll get to the cancer space in a second.
Got it.
But portal vein thrombus, bland thrombus, just from portal hypertension. From a surgical perspective, how much is too much?
Yeah, so we try to be as creative as possible. I think it certainly fits into, several different factors coming together. We're a lot less ambitious if the BMI is 50, right? It's just technically doing that bypass or getting that vein open and having a successful recovery period goes down tremendously. So the weight and the body habitus plays in quite a lot. Most of the time, so our approach at our center is we always start with thrombectomy, intraoperative thrombectomy. And so if that clot is contained just to the portal vein, then most of the time, and it looks like it isn't too chronic and organized, the calcified portal vein clot is, no fun for anyone. But if it's relatively fresh clot, then we'll try to do a thrombectomy. If not, we can look at bypass options. Probably the most reliable and best outcomes are with a bypass from the superior mesenteric vein, where we take cadaveric vein and we make a new portal vein. Once you get outside of those two options, now we're looking at inflow options that have much poorer outcomes. You can use, if there's a lot of collateralization between the splenic vessels and the renal vessels, typically on the left side, then you can take the left renal vein and put a conduit and bring that up for portal inflow. We've done that a couple of times. That also can be a pretty tricky operation if they had SBP or any scarring. So all these options, are really, you don't want to go into it with that being plan A. So
plan A is usually you guys with anticoagulation, at least in my experience. That's how it is. So how do you determine whether someone's an anticoagulation candidate with varices and other bleeding risks, thrombocytopenia, et cetera?
Well, I'll say, because I'm a little older than you, this has definitely changed over the course of my practice. I think we used to have a lot of fear about anticoagulating this patient population. And in fact, what the data have shown that, as you understand, I know the presence of a portal vein clot is actually increasing the severity of portal hypertension. And so with that, you may have enlarging higher risk varices that are more likely to bleed. So if you identify clot before it's, sort of recalcitrant, calcified with extensive cavernous transformation, then you can reduce the risk of variceal bleeding by anticoagulating. I think most people would do an endoscopy before initiating anticoagulation. Yeah. And then, the other issue is sorting out what to use to anticoagulate these patients. I think the safest is often low molecular weight heparin. The DOACs are a little bit tricky depending on the severity of liver disease, and warfarin can be complicated because we don't know necessarily where to aim the INR target.
Yeah, I think the other thing is we don't have great data yet for the DOACs and how safe they are to use in cirrhotics. It seems to be that they're pretty safe. But the other thing that we want to consider is their transplant candidacy. So if they're on a DOAC and they get called in for transplant, how easy is it going to be to reverse that? One is the ease of getting the medication. Two is the cost. The reversal agents for some of them are very expensive if they're available. Our practice is typically to use warfarin if they're listed for transplant. That way we know that they're easily reversible if they get called in for transplant, because the timing of that is unknown. Low molecular weight heparin is another option because that's also easily reversible. So a lot of it will depend on their transplant candidacy. But I agree, we definitely would want to scope them before, make sure they don't have varices, ban them ideally before starting them on anticoagulation.
And how long would you give anticoagulation a shot before you start thinking of interventions to help? Because occasionally I find ourselves doing some sort of intervention like portal vein recanalization in order to make the transplant easier. If we can get the vein open before transplant, like a TIPS portal vein recanalization. But what's your guys' experience with when we think about doing that?
Yes, that's a tough question. I think that's when we get into our multidisciplinary conferences and we talk with interventional radiology, with transplant surgery, with hepatology. One, to know, how easy is this going to be accomplished? Is this going to be an easy interventional radiology procedure? Is it going to be time intensive, risky for the patient? Is it really going to benefit them? We've done it a few times, and the ones that I've personally seen have been successful. But it's definitely something that we would talk about with our whole team and not just one person saying, let's do this and go forward with it.
Would it be 3 months, 6 months after anticoagulation? Or
I've seen them do it even before they're on anticoagulation and then put them on anticoagulation after. So I don't know if there's enough data to say what's the right answer or not.
Well, that's the big issue, right, is we don't actually know the answer to this question. And so we got to operate in that space of what do we think is safe for the patient. We certainly think about, so preemptive TIPS, I think, is a really interesting topic, and that's emerging. We don't have great data, but I know there's a lot of centers doing it, especially like a relatively small caliber TIPS bypass just to decompress that, and you get better flow, and that maybe even in combination is going to help with these partial portal vein clots. We've had a couple of pretty aggressive approaches where we knew we needed to get the portal vein open to make them a good candidate, and they've done thrombectomies and the transplantic approach and open things up. The only thing I would say is that the one that has caused me a good deal of headache, so talk to your surgeons, your transplant surgeons, before we start tipsing them, because if you park that portal vein stent under the pancreas in a cirrhotic patient, that is a treacherous thing. Even though the portal vein is technically open, that is pretty treacherous to try to reconstruct around. And so that's one thought that I have about it.
And then also from a technical perspective, at least the transplant surgeons I've worked with said the other end on the hepatic vein side, not going into the right atrium can be tricky too.
Yeah, please don't. Yeah, we don't like to get into the chest. We leave that to our cardiac colleagues. I've only had to do that one time where we had to open the pericardium and put a clamp up high, but that's a headache. And that's where, what this kind of comes down to is having good relationships with the providers in your network and the ones that you work with so that you know to make that phone call ahead of time and you kind of know how it's done. We get into tough situations when people get, IR therapies in places who aren't familiar with transplant and kind of don't know to avoid these sorts of things. So it's great to get that out there.
I think the other thing to bring up too is taking into consideration their liver function. Like if they have a high MELD score and you go in and put a TIPS in, you have a high chance of making them sicker and potentially ineligible for transplant if they get too sick or things like that. So not always putting a TIPS in somebody who's really sick. You could potentially do more harm than good.
Definitely. All right, so let's move on. So still pre-transplant, now they have cancer. How does transplant and cancer, HCC specifically, although we are transplanting for a bunch of other cancers now, specifically HCC, how does that work? Does it change how they get transplants or what?
It does. So if the sole reason for transplant is HCC, it changes definitely their wait time for transplant. So the way that it works in the United States is that patients are listed at whatever their MELD score is. And so if somebody with HCC has a normal MELD score, say it's 6 and they have HCC, they'll get listed at a 6. If they don't get transplanted within the first 6 months of transplant, which most people don't, unless there are sort of unforeseen circumstances, then after the 6-month mark, they are potentially eligible for what's called exception points. And so they get listed. It's a little tricky now and it changes every few years. But right now, what happens is they get listed at the median MELD -3, where the donor passes away, which is a little tricky and difficult to understand. But basically, whatever the average MELD score is at the time of transplant, they get listed at 3 points less than that to help them move up on the transplant list and get listed and get transplanted.
Definitely. And is that for all cancer patients, or do they have to be certain kinds, or what are the criteria to get these points?
Well, they have to be within certain size criteria to be eligible for it, which typically we refer to as Milan criteria. We probably will discuss downstaging. So, over time, we've been able to make transplant an option for HCC patients as local regional therapies have improved, and we've just learned more about, how to identify people who are going to do well. But to be eligible for the standard exception points that we just heard, those are for cancers that are within Milan.
And so remind me, what is Milan criteria again?
So Milan criteria is a single tumor up to 5 centimeters in diameter or up to 3 cancers, each of which are under 3 centimeters.
Yeah, 3 less than 3 or 1 less than 5.
Yes.
I think I have it in my head.
Yes.
And we have to chime in here, too, that's based on a study from Italy a long time ago with 46 patients. So it's crazy to me that in 2020, almost 5, that's what we're basing this on. It has played out in other validated studies, but that's crazy to me.
Yeah, and so something we debate in our tumor board all the time is this concept of there's no such thing as a 19 millimeter HCC.
That's a bad radiologist.
Yeah. Can someone explain to me why that's important as well?
Yeah, so for exception points from UNOS, you have to have, if it's a single lesion, it has to be at least 2 centimeters to qualify for those exception points.
Yeah, and so at least from an IR perspective, that's super important because we have some people who get treated in the community where they're maybe not at a transplant center. They'll have a 15 millimeter tumor, 1.5 centimeter tumor. They'll get treated and they'll come to us for transplant, and then all of a sudden we can't transplant them because they can't get the exception point. So that 2 centimeter, is ingrained in my head, and anytime at tumor board, they're right, there's a 19 millimeter tumor. We're like, are you sure it's not 20? Et cetera. Okay, great. So let's say somebody is within Milan criteria and they are UNOS T2, so 20 millimeter tumor. We start talking about bridging therapy. So they're listed for transplant. Do you guys have any preference for bridging therapies, or what's been your experience with all of that?
I mean, at our center, we mostly use Y90. If it's a small tumor, and especially if it's not transplant relevant, then ablation we'll use. I think it's center specific if they're more experienced with TACE versus Y90. If you look at the ASLD guidance, they don't recommend one over the other. So it's whatever your center is, most comfortable with.
These decisions are best made in a multidisciplinary tumor board conference, taking into account, size, number, location, local expertise, proximity to vessels, et cetera, to decide what the best bridging treatment is. But yeah, there's no current guidelines don't advise TARE over TACE at this point for that purpose.
Okay, perfect. And from a surgical perspective, I've heard, whether it's true or not, I'm not a surgeon, so I can't answer it, that TARE has issues with adhesions and makes the surgery harder. What's been your experience with that?
But I mean, so I don't know. I think there's two sides to that coin. Ultimately, I care about a good outcome for the patient, right? And so if they don't get good control of their tumor, they're never in the operating room for the transplant to begin with. So anecdotally, and this is not what we should necessarily make decisions on, but because we have this sort of equipoise between TACE and TARE, our center has shifted in the time I've been there, so over the past 10 years, from TACE to TARE, and it seems like we get much better and longer tumor controls. So we're seeing more patients in the operating room, particularly in the downstaging, like you said, that we'll get to in a minute. It causes a lot of adhesions. It's annoying for, an hour. But then once you get things freed up, it has never been a point where it affects the quality of the outcome of the transplant, with a possible exception that folks who have multiple treatments with TARE or TACE really can get a lot of inflammation around the artery. And so sometimes when you're doing that arterial anastomosis, it's like butter, and then I'm cursing my guys, but that's okay. It works out in the end. There's lots of options to fix it. So getting to transplant is what I would emphasize.
And so particularly for our downstaging patients, that's important too, because we need to have an effective therapy that they have a slightly more aggressive cancer, the duration as well. So I guess what percentage of patients in your guys' experience are successfully able to be downstaged to get to transplant? Just gestalt.
Yeah, I mean, I don't know an exact number, but I would say a fair number. A lot of it will depend on the tumor biology, which you can't always, you don't always know up front. So there are some people that have, one or two lesions that you treat them, and then when you get surveillance imaging a month or 3 months later, they have like multiple new lesions. So obviously the tumor biology is going to be really difficult to control. But I would say the vast majority, assuming they don't have a really aggressive tumor biology, we are able to downstage. It's pretty rare that we get people that keep popping up with new tumors that we're not able to downstage.
Yeah, we usually get good intrahepatic control for the downstaging. The Achilles heel is that something pops up in the lung or something later, and kind of the cat's out of the bag there.
Right, and unfortunately, sometimes it's post-transplant when we see that.
And we'll get to that too. Great. So let's make a little transition now from pre-transplant to peri-transplant. What's the day like for someone getting a transplant, the patient?
Yeah, that is highly variable. It's obviously a big day for the patient. There's a lot of new technologies that change that experience as well. In most cases, they have been waiting on the list for a variable amount of time. They get a phone call and they have to come in. And every situation is a little bit different. We have some cases where it's a very last minute offer. It's very rushed. It's very stressful, and they kind of come in and get transplanted. In other cases, we know that there is an organ available. They come in to get their transplant, and we'll wait even days before the donor goes to the OR. So that can kind of vary quite a bit. We try to avoid that stressful situation where they're rushed in to get a transplant. And you made an allusion to some of the pumping technologies that gives us a little bit more control over when we do those cases and do them during the daytime and doing it in a little more controlled fashion. The other variable that can really be stressful for patients is we often have a marginal graft that we think is going to potentially be a good option. And so they will come in and they can drive in multiple hours, sit in the hospital for 2 days, only to have it be not a good graft. And so we end up having some of our patients on the list get called in even dozens of times, and that can really wear on people psychologically. We know when people are going to get transplanted if they have a living donor. So with living donor transplant, then they already have that date scheduled, and the anxiety is really lowest with that.
So who can get a living donor transplant?
Anybody is the first answer. There's very few cases where you can't. Maybe in some centers when there's complex portal vein thrombosis or liver retransplant, those would probably be some of the hard stops where we wouldn't do it. At least we wouldn't at our center. There's a couple centers that do even do it in those situations. The trick is that not every center does living donation. It's not an option everywhere. And so we have to kind of figure out how to connect patients who have donors with centers that do them.
Awesome. And you mentioned this pump. What is this pump?
Yeah, the pump. So your hometown here are one of the national leaders in that. There's this explosion that happened in liver transplant over the past 2 or 3 years based on this idea that once an organ is recovered, you can sustain it outside of the body, outside of the donor's body, on a circuit of blood and keep it oxygenated and keep it warm. So that's really important because it gives you metabolic function from the liver, and you can do further assessments and you can keep it stable for longer periods of time. So all those cases where, you're ready to start the transplant at 11 p.m., those start to go away. And you do it at 6 a.m. and you have more information about the quality of the graft before you sew it in. It allows you to take a lot of those marginal organs that I talked about, and if you need more information about it, you put it on a pump, and you can take organs that would normally be buried and put them in to carefully selected patients. So it's really revolutionary. It's super tricky. We need like 8 sessions to go into the finances of this because it's quadrupling the cost of transplants. And, if you had a CFO in here, they would be up in arms. But again, we're all trying to find out the best system we can do to take care of patients, and pumps are the future for sure.
Awesome. And speaking of marginal grafts, a lot of my patients are, at least I read your guys' notes, and they say, willing to accept like a hepatitis C transplant. So do you only give a hepatitis C positive organ to somebody who has hepatitis C, or can anyone get it?
So it used to be the case that we would only consider transplanting a hep C positive organ into a hep C positive recipient, but the advent of highly effective, safe hep C therapies, the DAAs, have completely changed that equation, where now it can be considered to be transplanted into anybody. Now, there has to be an informed discussion with the person on the wait list to see if they would want to consider that and understand, what that means and potential risks of it. But it, I think, has, maybe not as much as the pump, but certainly helped to expand the donor pool.
Mm-hmm. And what about HIV? Are we able to use HIV positive livers into HIV positive patients, or?
I think, and you guys might know better than me. It depends on the center, I think.
Yeah, it has to be somebody who already has HIV, so an HIV positive liver going to an HIV positive recipient. We can't put an HIV positive donor to somebody who doesn't have HIV. But
Canton wouldn't.
Correct.
Right.
And would not. Correct.
Okay, good.
But are all centers doing, or it's just selected centers doing HIV?
It's pretty liberalized now. In the trial, we were in the trial phase, and so we've been doing it for a little while. It doesn't come up in that much, but hey, every liver counts, right? So it's pretty exciting when you can do that.
Awesome. So in the last few minutes we have, let's move now from the peri-transplant period to the post-transplant period. For patients who have tumors, I know a score is calculated called retreat. I don't know if one of you guys could explain what retreat is.
Retreat is a scoring system that was developed at UCSF, where they've done a lot of the sort of landmark research around transplant for HCC, and looked at a number of factors to see if they could help predict the risk for HCC recurrence. And catch me if I forget some of these, but the AFP at the time of transplant, the amount of viable tumor on explant. I think they look at things like vascular invasion, things that would speak to a more aggressive advanced tumor that is going to be associated with a higher risk of recurrence. And that then can be used to inform how patients are surveyed and for what duration.
Is that universally used, or are there any other scores that people use?
It's really center dependent. We at AstraZeneca don't rely strictly on the retreat score. It comes up occasionally, but we look at some of those same things. Is there viable tumor on explant? Part of our multidisciplinary approach is to review all of our explants and a pathology conference, which is multidisciplinary, to see if there's any viable tumor, vascular invasion, sort of the same things that were mentioned. And based on that determines if we monitor them for 5 years or 10 years after transplant.
With imaging? With imaging
and AFP.
Yeah, at the end of the day, it's kind of like, what are you going to do with that information? And you're going to get a CT scan every 3 months or 6 months? That's largely what it dictates. And we have some systemic therapies, but most of them you can't use in the setting of immunosuppression anyway. So, I think it doesn't change clinical practice that much whether you strictly use it or not.
Yeah, I think the big thing is I want to say they stopped screening some patients at 2 years if they're, really low risk.
I want to say, I haven't looked at the original study in a while, but I think they were even arguing that if you were a 0, that you didn't need any surveillance. Though I think even the lead investigator was like,
that's a tough sell to a patient too.
We're not really
we got it all. Are you
comfortable.
sure?
Yeah.
Well, can we check? Sure, we can check.
And so something that plagues us, as you alluded to, is recurrence after transplant. Is let's say extrahepatic recurrence, is repeat surgery ever an option?
Oh, it's an option for sure. I haven't surveyed the literature on that recently too much, but certainly the studies that I'm aware of show really not great outcomes if it's extrahepatic recurrence. And even going back in to operate on a liver post-transplant, my hunch is that the tools we have that are less invasive are going to get you the same outcome and survival as opposed to going back in and doing surgery for an intrahepatic recurrence.
So stepping away from the tumors again, what are sort of complications post-transplant we could run into anatomically?
I don't have any, so you shouldn't have. No, this is there are really challenging to manage complications, and we lean really heavily on our interventional group to help manage those, because it has shifted tremendously again over the past 10 years, where a lot of these were reoperations that were really difficult and didn't have necessarily great outcomes. Most importantly probably most common would be biliary stricturing. And some of that can be done endoscopically, but often when you have complex cases, it requires PTC tubes to be placed and serial dilations of strictures. It's really important in the context of living donation. So the one Achilles heel of living donation is the bile duct perfusion isn't quite as good as a normal bile duct, and stricturing is a lot more common. So interventional management of those is really key and bails us out. And then for arterial narrowing, we also work with our interventional group at our center that do all of our stenting that narrows over time.
And how about immunosuppression? How does immunosuppression work? Is it continuous for the rest of their life? Does it change over time? How does that work?
So for most people, it is for the rest of their lives. There have been, some studies suggesting that there are some patients who may be able to be completely weaned off, but that's not widely practiced. But the amount of immunosuppression certainly decreases from the time post-transplant. The risk of rejection is highest at the time of transplant and then lowers over time. So they start off on, again, very center dependent what the protocol is exactly, but usually a calcineurin inhibitor like tacrolimus and anti-proliferative like bicafenylate mofetil, and then some steroids. And then over time, the steroids are peeled off, the MMF gets peeled off, and people, for the most part over the long run, get maintained on a single agent.
Okay, great.
I think the caveat there is probably beyond the scope of this, but transplant and peds, so small kids with tumors, they are the most likely group to develop some degree of tolerance and come off completely. And there's a lot happening there, but that's a small piece of the pie.
And there's other things that we factor into as well, like their kidney function. The CNIs tend to have more nephrotoxicity. And so somebody who may have CKD, either pre-transplant or post-transplant, sometimes we'll keep them on MMF or another agent like the mTOR inhibitors to try to lower their CNI.
And then I personally do a lot of biopsies to rule out rejection. I think that just might be more of a reflection. We do a lot of transplants, and, even if a small percentage of a lot is still going to be a lot, at least in my perspective. How do you guys manage that? So let's say someone has some sort of rejection. I guess what are the types of rejection you can get?
Yeah, so with liver, it's usually acute cellular rejection. It's pretty rare for us to run into antibody-mediated rejection. Some patients, especially with mild rejection, just increasing their immunosuppression, their oral immunosuppression is enough to control the rejection. So increasing their tacrolimus a little bit, increasing their CellCept may be enough. If it's moderate or definitely severe rejection, that typically requires IV steroids. So we'll hospitalize them, give them a few days of IV steroids, try to bump up their oral immunosuppression as well. And then typically we'll keep them on two agents. So we'll keep them on steroids for a while, and then once that's weaned off, we'll keep them on both a CNI, and typically MMF is our second agent that we use.
If that fails and we start talking about retransplant, how is that discussion had? Do they get points again, or how does it work for someone who needs a retransplant?
I mean, it's pretty rare that we run into that, thankfully. The times that we do, it's typically patients who are not very compliant with their medications, and they run into multiple episodes of rejection, and they end up getting chronic rejection, which is a little bit different than cellular rejection. And it really depends on the reason for it. So if it's somebody who's non-compliant and they're, after going through a re-evaluation or deemed to be an acceptable candidate, they may be able to be managed the same way we would manage somebody that that had their first transplant, obviously with more, instructions on compliance and things like that. Sometimes we run into it with people who have really difficult to control autoimmune hepatitis, and they just have a really robust immune system and they run into lots of rejection. So those patients we typically will keep on 2 agents, and sometimes we even have people that need to be on 3 agents to decrease the risk of rejection.
And from a surgical perspective, retransplantation?
Yeah. It depends on kind of the reason and the indication. The one that is really challenging to deal with is, we try to maximize utilization of the donor pool, right? And that means we're using some grafts that have some risk factors. Unfortunately, some of those grafts end up developing ischemic cholangiopathy, which I know you all see, and we try to manage that as best we can. But those are the patients that probably suffer the most on the retransplant because they often get stuck with a low MELD score. Depending on the circumstances, they may not be eligible for extra points, and they really sit there and suffer until we find some circumstance where we can get them retransplanted. So those are really difficult. The management of those is also very multidisciplinary, and it can sometimes be improved or temporized with some of the interventional procedures that y'all do. But yeah, that's the one that's probably the biggest pickle.
Well, as we finish up, is there any last minute big thing we need to know that's in the pike that's coming in transplant? Any new innovations that are either increase the amount of livers that we have or change how well they do afterwards?
Pump is still, the most exciting thing, and it's not widespread. So I think that's what we're focused on now. I'm not aware of, other devices or things.
Yeah, I think there's a couple ways to look at that. Like one big thing is going to be transplanting fewer people, hopefully, right? So we have to remember we just basically cured hep C. So everything has shifted so much recently. It used to be all hep C and you couldn't fix it. So a little bit of acknowledgement that there's a lot of medical progress, right? And so not transplanting people would really be awesome. Although not until my kids finish college. Then we can stop that. The pump game is great. The living donor game is great. And, if we want to do pie in the sky, we got to look at things like organ engineering and xenotransplantation. And they're not really ready for prime time, but they're not ridiculous ideas. And that's something that would be neat to see in the future.
So xenotransplantation is like pigs?
Okay. Yeah, pig livers. And so obviously there's a lot of barriers to making that happen. But you've probably seen in the news media that's happened with kidney a couple of times. And, there's a lot of research into that. I'm not the one doing it. But if we can find a solution for our organ shortage, then we can treat patients in the way they should be treated regardless of waiting time and issues like that.
Awesome. Well, with that, I want to say thank you guys for joining me today. I learned a lot. And so I want to appreciate you because I think our audience did as well.
Awesome. Thanks so much for having us.
Thanks for having us.
If you enjoyed this episode, go follow or subscribe to BackTable Tumor Board on Spotify, YouTube, or Apple, where you can watch or listen to the full season covering all things HCC. We brought together leading experts in oncology, interventional radiology, hepatology, and hepatobiliary surgery for discussions that matter and to help you level up at your own HCC tumor board. You can keep waiting for each episode in the season to drop Fridays on the VI show, or you can go follow or subscribe to BackTable Tumor Board and get them all, including the full video discussions and tumor board kits reviews on Spotify and YouTube. Enjoy!
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.